Welcome everybody to the Francisca Genitourinary Oncology Tumor Board. My name is Brian Reaney. I'm a professor of medicine at Vanderbilt Ingram Cancer Center in Nashville, Tennessee. And I'm pleased to be joined today by a panel of experts, and we're going to talk through a number of kidney, bladder, and prostate cancer cases.
My name is Jason Abel. I'm a surgeon. I'm a urologic oncologist and associate professor at the University of Wisconsin.
My name is Maha Hussain. I'm a geomedical oncologist. I'm a professor at the Robert H. Lurie Comprehensive Cancer Center, Northwestern University, and I also serve as the deputy director for the Cancer Center.
Hi, I'm Tyler Fromm. I'm an assistant professor of radiology at the Washington University School of Medicine in St. Louis. I specialize in abdominal and pelvic imaging as well as nuclear medicine. Glad to be here.
My name is Pritesh Patel. I'm an associate professor of radiation oncology at the Winship Cancer Institute at Emory University, focusing on GU malignancies.
76-year-old man with a history of recurrent stage 4 adeno of the prostate with bone metastases, currently on leuprolide. Originally diagnosed in 2012, had a radical prostatectomy as well as radiation to the prostate bed, and now with rising PSA and a thoracic spine abnormality. And so we're going to talk about the approach to this bone scan abnormality and sort of the sequencing of radiation and hormones. So this patient years ago presented with the rising PSA, good performance status, medical history of hypertension and diabetes, but no relevant social or family history. The oncologic history dates back to 2012. Had an elevated PSA, was worked up and got a transrectal ultrasound biopsy, which showed a Gleason 4+4 adeno, underwent a radical prostatectomy at the time with the pathology you see listed there, had a quick recurrence at an appropriate PSA nadir, but then a quick recurrence of PSA and got radiation to the prostate bed as salvage. Had a PSA nadir for a while, and then about 4 years after the salvage radiation had PSA further rise. And at the time, and this is not listed here, this is my patient, but at the time actually had a bone scan that showed a solitary thoracic abnormality. It was never further characterized at the time. There was no biopsy, there was no MRI. This was well before sort of newer imaging. And so the patient was just started on hormones. The thoracic abnormality was asymptomatic at the time. Was started on hormones. PSA went down for, as you see, about 4 or 5 years. And then PSA starts to rise, is re-imaged with a bone scan, and has an unchanged thoracic abnormality. So it was there in 2016, was not imaged in the interval when his PSA went down, and then came to see me with a rising PSA on Lupron and this unchanged abnormality. And I wish I had a picture of it, but it's just a black spot on a bone scan. One of the questions is about, do we need to diagnose exactly what this bone scan abnormality is in terms of whether or not this is really metastatic disease that's just been treated with Lupron, or is something else like degenerative disease and we're just dealing with a non-metastatic castrate-resistant patient? So let me ask Dr. Fromm first. So again, this is conventional bone scan in 2016 and now. And it's a very typical abnormality, right? It's a black spot on the spine. It doesn't, patient has no history of trauma or anything. What would be your next step? Let's say you have all the imaging available in terms of PSMA PET, et cetera, or just a regular MRI. What would be your next sort of imaging test you do, presuming you want to diagnose what this is?
Well, I guess if I were the one reading the bone scan and really having to interpret the imaging study in question, not all foci of uptake on a bone scan are created equal. There's some subtlety to the pattern that one tries to kind of pick up on looking at these studies, and always doing if there's no known diagnosis of metastatic disease and no CT or MR to correlate, then getting a SPECT CT can give you a sense of the precise location of the abnormality, and also a better sense of what it's most likely to represent. Because as you said, degenerative changes, some benign osseous lesions can in fact have increased uptake on the bone scan. There's no specificity for prostate cancer there. but assuming we don't have any of that other information and it's just a solitary, spot on a bone scan, I think doing, an MRI would be, reasonable first step to see whether, this looks like a marrow replacing lesion versus, perhaps something that's more end plate centered that could be degenerative. But I think, the PSMA, PET is going to, be more specific for determining the etiology of this lesion. So
PSMA PET if possible, and obviously that gives you a picture of the other bones in case there's other disease. But if you can't get that, that MRI is certainly a reasonable diagnostic test.
Why not Axumin PET? You can do it now.
Yeah, that would be reasonable as well if PSMA is unavailable. It's just that I can't remember what the PSA was at the time that the scan was done, and the detection rates are lower with FACBC PET than they are with the PSMA agents. So a lot of it's going to sort of depend on institutional availability of different tracers.
How high was his PSA, Dr. Rini?
Yeah, I'm trying to remember. I think it was 9 or 10, something in that range.
I mean, I think his insurance should cover an Axumin PET. It's almost like a given. I shouldn't say 100% given, meaning
but it's likely, yeah.
But I think so, yeah, because generally in my experience, at least in cases I see in Chicago, the borderline is like a PSA of 2 minimum. Yeah. So in his case is that way.
And so I think
doing.
Go ahead.
I was going to say, I think with that PSA doing an FACBC PET, you're not going to see much of a difference in the detection rates probably between PSMA and FACBC at such high PSA levels.
So we do an Axumin PET scan, and this one bone lights up, nothing else lights up. So we're fairly convinced it's a metastatic focus. So Dr. Patel, the patient's totally asymptomatic. Would you radiate this lesion?
Oh, it's enticing, isn't it?
That's why I ask.
Yeah, this, I think we touched on this before, sort of an oligoprogressive situation. This is a data-free zone in terms of decision-making. This is a perfect case to bring to multidisciplinary tumor conference to have a discussion about really about systemic therapy. What is the next line of systemic therapy? What is the toxicity? What's important to this patient? And does a local therapy help us with an endpoint like maintaining the current systemic therapy, which we're happy with, for example? That might be the best short-term benefit that we know about for the use of radiation. But the thoracic spine, now we're probably talking about SBRT, and there is a risk of pathologic fracture after SBRT to the thoracic spine. So, you want to be careful there. So, I'd probably get a CT scan just to assess the structure of the bone. There are other options if you're worried about the bone integrity. So, maybe even an ablation and a kyphoplasty. But if everything looked okay on a CAT scan, which, I think you get that from an Axumin, I think it would be reasonable if the team and the patient were desiring the outcome, which would be maybe delaying a change in systemic therapy.
Fair enough. Dr. Hussain, how would you approach this patient? Solitary bone met, rising PSA, but perfectly healthy, asymptomatic on Lupron.
Sure. I think I agree with all the recommendations. The one thing I should highlight is this, and this is something that on the meta-onc we see this a lot. Check testosterone to make sure that the patient is adequately castrated, because I will say that with the injections that they get, I've seen a lot of times weaning off the effect. Is he on Lupron or what is he on?
Yeah. He was castrated, his testosterone.
Yeah. And so irrespective of the drug, what I see with the LHRH injectables, specifically towards, sometimes we see cases where towards the end of the cycle for that drug, you end up getting a weaning off of the effect for some reason, and then testosterone goes up. So I would definitely just become a habit regularly, and certainly the guidelines would recommend this. I think this is where the conversation with the gentleman becomes important in terms of prioritization. No question that he's earned himself systemic therapy intensification moving forward. The issue comes up, it's a matter of timing. And if in fact, as Dr. Patel pointed out, it's a risk-benefit issue. If if the Axumin PET is negative, this is the only area where you think this is coming from, I would recommend, consultation with radiation oncology, and then see if you get mileage from the radiation. Obviously, there's no guarantee. So this is really where the pros and cons have to be discussed. And of course, if the Axumin PET is negative, essentially he falls under the category of non-metastatic, quote unquote, castration-resistant disease. And depending on his PSA doubling time and other comorbidities and such, there are different options of treatment with oral AR inhibitors, AR targeted treatments.
So just to summarize, it sounds like some sort of imaging to confirm the abnormality, confirm maybe lack of other abnormalities, consideration of radiation, and then at some point he's headed towards secondary hormones, whether it's sooner or later. I think that's just a conversation.